Good morning, everybody. I think, are we on the go? Okay. Good morning, everyone. Thank you for braving the horrendous conditions this morning and coming in. But as has been pointed out to me, where else would you be today, really? It's not gardening weather. So we've got a really fascinating day lined up for you. I think you're going to get a lot from this. If you've got any questions, either grab me as I'm flying through or my people out on the registration desk, but hopefully everything's clear. Bathrooms, you should know, there's a couple just out there by Preston A and then out in the registration area, and all the catering will be out there with the trade stands. So first of all, thank you, and also to thank all our sponsors on the next slide, please, Grant, who have actually made today possible, because without them we wouldn't be here and be able to offer this to you. So please make sure you go and see those that you can. Lyrebird, unfortunately, is stuck in Broome at the moment, so we give her our heartfelt sympathies. Not. So, first of all, I'd like to acknowledge the traditional owners of the land on which we're meeting, the Wadjuk people of the Noongar Nation, and pay respect to elders past, present and emerging. It's now my very happy job to hand over to Belinda Russell-Smith, Dr. Belinda Russell-Smith, so familiar with her, who is chairing our meeting today. Belinda, thank you.
Thanks, Wendy. I'd like to extend my own very warm welcome to all of you. There's lots of wonderful faces that have attended our women's event earlier in the year, and I see you're back for more today, which is a wonderful reflection on you all. I'm really proud of the lineup that we've got today. I think it'll be a really great day of education. So I'm also looking forward to meeting more of you through the day, so that you feel comfortable reaching out to me in my role as Hospital Liaison GP if there's any concerns or suggestions that you have. So feel free to grab me through the day as well. But I'd like to hand over to Dr. Lana Bell, who I'm sure most of you know. She does a wonderful job at Joondalup, both with her hat as paediatrician and also a lot of hard work behind the scenes in other areas as well. So welcome, Lana.
Thank you, Belinda. Can everybody hear this okay? Is the sound coming through? No? Okay, let's go with this one instead then. Good morning, everybody. Thanks for coming. I've got a lot of familiar faces in the room. We'll just try to get the slides up. While that's going ahead, I just wanted to say thank you to Wendy and Belinda for organising today. They've done a fantastic job, and you do have a very good lineup of speakers. If you haven't heard Michael Collins speak, he really should be in stand-up. He is very, very funny. Paul Sanders not far behind. So I'll just introduce myself first. My name's Lana. I'm a paediatrician. I'm a UWA graduate. I won't tell you which year. And then went straight to paediatrics at the old PMH before obviously then transitioning into the PCH. And I've had my foot in both camps for about 10 years between Joondalup Health Campus Paediatrics and PCH. And then I moved up to Joondalup full-time to take over the head of department role there back in 2020. So since then I've been out of PCH world and just at Joondalup Health Campus, both as a paediatrician, but now also with a digital role and Deputy Director of Medical Services. So I'm going to tell you a little bit about the hospital in general and how it's expanding, as well as how paediatrics is expanding. So the white bits is what the hospital used to look like, and the blue bits is the new builds that have been going on in the last few years. So you can see the private expansion of theatres, which is taking place now, and also the ones that are already built, the mental health unit, some staff parking, a big public parking block here. And then the ones that are currently underway is the new theatre expansion in the centre of the slide, and down the bottom in the more purpley colour is the new private hospital expansion. So for some years now we've had at least 2 cranes overlooking the hospital when you drive in, one really building the private sections and one building the public sections. The private section's new one down the bottom there, as you can see, is not quite open yet, but everything else is open. So we've had a lot of expansion in a relatively short period of time. There we go. So this just shows what we've been building and what's been completed and still to come, and does give you an idea of how many extra beds and bays and theatre spaces we've got available. So 12 extra bays in the ED, extra parking, the mental health unit, 55 beds there, one theatre in the public redevelopment space so far, one additional cath lab, but we actually have built 2 new ones, the old ones being decommissioned and changed into a procedure room. Extra 30 beds, and I didn't get time to change my slide, but there where it says 60 shelled beds, you might have seen that the government has just announced a couple of days ago that those 60 shelled beds are now going to be opened. It will take us 12 months to fit out that concrete shell at the moment, but those 60 beds will then open in about 12 months' time. And we've got a new cardiac unit as well. It's got 12 public beds, but also 6 private beds. This is just highlighting the new areas which are just about to open. The CCU was completed in June. The 2 new theatres on the public block with the new labs is opening August, September, and then next February we'll have the private ward build. This is what it used to look like a few months back for K Block, and K Block is where our new cardiac centres are, which has now just been completed. You can see it there with all the panels. And then J Block is the new private space. This is late last year. It's 4 stories, so it's quite a significant expansion of beds, which will be due in February. So moving on to peds, we've also had a significant expansion of paediatric services. I did a head count of how many paediatricians and subspecialists we've got, and there's 24, which surprised me, which shouldn't, because I've been the head of the department there. But it's amazing how quickly you grow and how many subspecialty peds we've now got in those areas. The ward itself is actually quite beautiful. It's really well fit out. It looks less like a hospital ward and more like a sort of kids' play space. It's got 23 rooms with 27 beds, so obviously most of the rooms are single rooms. We have a couple of double and 1 triple room. We have now got some public clinics running, which has taken about 15 years to happen, but we do have some public clinics. One is in paediatric allergy, and the other one is in paediatric rapid review. That's only just opened, just ahead of the coroner's case, and we are now allowed by the state to rapidly see kids from the ED who might be sent home and told to see a GP tomorrow and, of course, may not be able to get an appointment, so they can come back to the rapid review clinic if needed. That clinic is soon to expand to GPs to be able to see kids who they are concerned may not be emergency level but may need a rapid review. Obviously for medical conditions, we don't want to be seeing any of the developmental stuff, just for that extra layer of safety for the ED. ED PEDS is very limited by physical space. So the ED section of the paediatric section of the ED has got about 10 beds, but they fill up very, very quickly, and it's really hard for us to then turn those kids over. So we concentrate very hard on moving those kids upstairs that we can, so that we can free up those 10 beds to have the next kids from the waiting room come through. So some really fantastic initiatives for flow as well. We now also have paediatricians going down into the ED a lot more than we used to support our PEM colleagues, and that's allowed, again, a more rapid turnover of kids and more, a speedy sort of response to management plans, whether they're coming in or going home. Unique to Joondalup and probably Midland is the fact that the paediatricians are also doing the deliveries and the nursery. We do have 4 neonatologists there during the days, and the days are fully covered, but for after hours and weekends, it's the paediatricians who run the nursery and who are in attendance. So that allows us to all keep up our neonatal skills. And of course, we work across the private and the public sides for the deliveries. There is a 10-bed DPU area which we use for our surgical turnover for some of the ENT that you'll hear about later on today. And we have 13 registrars and 7 junior staff, many of whom cycle between us and PCH just to keep that continuity going. And of course, many of you in the room would know Desiree Silva, who's our Director of Research across the entire campus, but of course has a specific love for paediatrics and runs the Origins project as well. 3 general paediatric surgeons. As I said, you're going to meet at least one of them today. ENT surgeons as well. and subspecialties including cardiology, allergy, immunology, IBD, and respiratory that I didn't put up there, and Steve probably will will pull me up on that. So we are getting bigger quickly, which is fantastic to see. The next big step for us as a department is to make sure we're increasing our outpatients. That's tricky because we're funded by North Metro, so we have to be allowed to do it under the contract with North Metro. We are continuing to work with them to try to get that traction. But that's enough from me because you need to hear about medical stuff. I am very happy to take questions if anyone's got any questions about the logistics of the hospital or how the paediatric department runs. Otherwise, I will hand over to Steve.
Just use this or the handheld. Clicker, is this it? Just see if I can. Sorry, I'm not across the technology. Is the clicker across? Yep. While working that out. It's amazing how quickly things change. Not just in this field, but so this one here's this one. Oh, brilliant. In terms of the Joondalup, I'm up there now, but I trained and we all cycled through hospital in Joondalup. Not so long ago, it was basically a parking lot that was a sand lot and maybe half the bed space. I do recall being the registrar on Christmas Day and there were no patients. So they closed the ward and of course the doctor needed to be there, so all the nurses went home. And there was me sitting in the ward with just the Christmas tree. And I think when they exited, the nurses thought, they didn't realise I was in there because the doctor's office was still covered. So they turned the lights off. So it's a stick memory of Joondalup as being this ward that was dark and just the glowing lights of the Christmas tree. So it shows you how quickly everything's growing at the moment. Okay, so back to the topic. I'm going to run through this in two parts. I'm going to run through just the background of how I think about the little ones that have respiratory issues in general. And what you'll probably see more than anything else is kids with cough. It tends to be less wheeze and more cough. So I'll run through that in terms of how I think about the preschoolers with cough. And then I'll probably stop there and then change track and then start going into more asthma. Hopefully that flow works well. And I think I prefer it if people just interrupt me if you've got a burning question, because it's often easier to address at the time. So if you put your hand up, we'll stop and move through that. But there'll be opportunities right in the middle to ask questions if you prefer that. So let's get going. This is the typical patient I see, and I hope it sort of rings bells with you as well. So 2-year-old child has a background of extensive history of wheeze dating back to birth that seemed to have improved by 1 year of age. Currently has 6 months, corresponding with colder months, of repeated episodes of cough, especially when active. Mum has observed a regular wet cough and frequent rhinorrhea over this time, but is unsure of the exact duration. History includes eczema and a family history of asthma in dad, and allergies including hay fever. On examination, child is happy and thriving. They have a wet cough in your clinic, but has no audible wheeze or respiratory distress on examination today. Does this sort of story ring a bell for most people? This is the typical patient that I'd see in a community clinic. So what does this kid have? I won't go through the room because it won't take too much time. Asthma, recurrent viral wheeze, frequent viral lower respiratory tract infections, trachomalacia, bronchomalacia, protracted bacterial bronchitis, all of the above, none of the above. Does everyone understand what all of the diagnoses on this list are? If not, we're going to go through them all. So let's start from the top. Respiratory viral tract infections. I find it useful to know what the natural course is in kids and adults. So children, after having a virus, usually they cough for a short duration, but usually on average, so there's a bit of give and take around that. When you look at studies that have studied it, they cough quite a while, actually, surprisingly, 10 days. Adults, surprisingly, more. And I think that's if an adult actually does get symptoms, because mostly it's just runny nose, but if they do get a cough, it can last up to 2 weeks. So not surprisingly for kids, if you get back-to-back viral infections, you can get cough for quite some time, because if you imagine most kids will get up to 14 viruses. They're not always symptomatic, but if you actually follow them through a year, they can get on average up to 14 viruses, especially the little ones. So and they'll stack up in winter. So you will see a lot of kids, they get one virus and the next and the next and the next, which makes it quite hard to tell if they've got a problem or they're just running a usual clinical course. What you will get from the history, though, is they get a wet cough that goes to dry cough, that goes to wet cough, that goes to dry cough. That doesn't mean they don't have something else as well, but that's the typical progression. And then you complicate that again by some of the infections like mycoplasma, chlamydia pneumonia, and pertussis. They are infamous for giving 100-day coughs and irritated cough that lasts forever. So I think it's sometimes not easy to figure out exactly what's going on just from a viral perspective itself. From a mucociliary clearance point of view, this is the main mechanism which you clear your airways. So as a passive system, your airways have what would be like an escalator mechanism. There's little cilia that line all of your airway lining, and they do this. They flick and flick, and they flick all the stuff up in terms of mucus that gets embedded with anything else in there, and then clear. And they can move a lot of mucus. So I think this is relevant because if you damage your airways, and that can be with a bad viral infection, and you see lots of little ones that get this, it can wipe out that mechanism. And it can take up to 8 weeks for your airways to heal. And in that process, if you imagine things and that escalator is not working, it can exacerbate their symptoms. We'll come back to that. That 8-week period is relevant, and I'll show you why. But we'll come back. So why kids are a little bit different to adults? There's lots of reasons, but we're going to focus most on their compliance. So when we talk about compliance, it's how floppy and movable everything is. Your chest wall is supposed to be rigid to be efficient. Your chest wall stays rigid, and then your lungs move within that. But if you have slightly more flexible lungs, and little ones particularly, their bones are not hard yet, and their cartilage is also quite soft, so they can move their rib cage. And if you see a little one, especially an infant that's got a bad bronchiolitis, you'll see their sternum actually recess an enormous amount. That's a good picture there of what happens. And what that means is really inefficient breathing, because you're moving your chest wall, wasting all that energy, and at the same time not moving your lungs quite as much. That happens also in the airways, because all of your airways are covered in cartilage and it's supposed to keep everything rigid. So you imagine, instead of having rigid cartilage, that cartilage is floppy as well. When you're coughing, it collapses. That also creates the inefficiencies that are in kids. And I think that exacerbates a lot of their issues and why they get a lot sicker than the adults do. Not exclusively, but one of the reasons. So what that airway floppiness is in terms of Latin is malacia. Malacia actually means sick airways. It's not a great term, but it's what we call it. The key for this is those kids that have malacia, they're usually very little. They're usually less than a year old. They usually are happy wheezers, so they've never got any issues. They're always just noisy when they breathe. They're not rattly. They're not got a wet cough. There's usually no failure to thrive, and they usually leave them alone. They get better by 2 to 3 years of age. That's exceptions to that rule, but that's generally the case. And then you can break it down to where it is. If it's up here, it's laryngomalacia. They often sound like a squeaky toy. If you've ever got a dog toy and squeeze that, that's what it sounds like. Tracheal malacia is usually a lower pitch sound because it's your trachea that's moving, so they're more of a grunty breather. And then bronchomalacia, that's in the peripheral airways, and they sound more wheezy, and that's more expiratory. Usually we do nothing with them. We just let them grow out of it if they're doing well, and then if they're starting to get older and they've still got it, then we might think about seeing them. Okay, just to give you an idea of what this looks like. This is a kid with bronchomalacia. Hopefully the video works. I don't know how to... Can you do it your side at the back to make the video play? I don't think I can do it through the... Thank you. So you're going to see, this is what your larynx looks like there, the vocal cords, the pearly white thing. Side. So your trachea is supposed to be nice, round and rigid. As you go further down, you can already see, right, it's narrower. This is your trachealis muscle, sits at the back. And how narrow it can get with bronchomalacia. And you imagine this kid coughing, that airway is going to collapse and it's not going to move. So not surprisingly, you have a heap of mucus further down. Does that kind of make sense visually what we're actually dealing with a lot of the time? This is one of the more severe examples, but I think you can imagine milder ones being fairly similar. It makes it hard to go further, but I think you'll get past it and you'll see sometimes it opens up or it gets worse. So that's all mucus obstructing the lens. That's why it keeps like darting in and out with white. And if you go down further, it's still quite floppy into the bronchi as well. Often they run together. You get trachea floppiness and the bronchi slits as well instead of being nice round holes. And that's probably enough. I'll move on. That leads into prolonged wet cough. So the key question for me is the cough wet or dry and how long has it been going on for? And that sort of distinguishes between general viral run and bronchitis. So when we talk about bronchitis, protracted bacterial bronchitis is the thing that I think more, when we first started talking about this sort of 5-10 years ago, people look at us like we're making up something, but I think it's become a thing that most people are starting to get an awareness around. These previously, before it got this label, used to be called chronic bronchitis, but I think they relabeled that because if you think about chronic bronchitis, you usually think about hacking smokers. So they called it this incredibly long name that everyone struggles to like convey to parents without them getting confused. The hallmarks of this basically are more than 4 weeks of cough. And it's moist, wet cough. They often have this rattly, wet-sounding, gurgly, drowning sort of breathing as well. And these are extremely satisfying to diagnose because you give them antibiotics and they almost instantaneously get better. And the parents come back to you going, you've cured them after they've been like this for 6 months to a year. So for us, by the time we see them, it's usually a couple of years, it's really satisfying. So I'd encourage you to give it a go if you haven't done this before. So what happens in, yeah.
For these kids?
That might be on the next slide, but if not, I'll come back to it. I juggle my slides around, so it might have disappeared, but it's a very good question. So they often have wheeze because if you get inflamed airways, they wheeze, and also this overlaps into tracheobronchomalacia because the mucociliary clearance is not as good. We usually do nothing with them other than give antibiotics and it gets better. You sometimes need to treat them with 8 weeks of antibiotics, but you'll see an effect within a couple of weeks. And you know how I was talking about the airways take 8 weeks to heal? It's because of that. And if you explain this is probably the most important thing because parents, as soon as you say it might be 8 weeks of antibiotics, get very apprehensive. So what words you use actually do matter. I explain it to them in terms of tree analogies. You'll find that's the theme of this talk. So imagine you've got on the pavement, you've got a puddle of water sitting in a divot in the pavement in the shade of a tree. Until that evaporates, that puddle sits there, and if it stays there for long enough, it gets pretty gunky, and that's the way you have to think about it. Bacteria get in there, and then they go rampant, and it gets muddy, and it gets funky. If that happens in the body, your body will attack whatever bacteria is down there, and it will cause inflammation, which tops your puddle up. So until you give that chance for that puddle to evaporate, it's going to continuously get reinfected. So if you give a shorter course of antibiotics, sometimes you'll find that they get better. But as soon as you stop the antibiotics, they get worse again. And that's typically what you see. So you bring them back 2 weeks and they'll be, oh, it worked really well, but they've suddenly got it again. And you're waiting that 8 weeks for the airways to heal, restore that sort of escalated mucociliary clearance function again. And then they usually come good after that. Sometimes they'll get it again, maybe because they've got tracheobronchomalacia, and then they get it again. You do the same lot. The time that we start to get worried is if they've had sort of 3 or 4 courses of antibiotics back to back. They just can't come off the antibiotics, and then you start to think that they move into chronic obstructive lung disease, which I think is one more slide ahead. I'm getting ahead of myself. So we commonly will give 4 to 6 weeks of Augmentin for this. If they come right within a couple of weeks to 3 weeks, it hasn't been going that well, you can probably stop there. But we'd say, like, our threshold would be, we go up to 6 to 8 weeks sometimes. Usually in that first couple of weeks, we'll find something. If it's going to work, it'll work very, very fast. The parents will say that to you in the first couple of weeks. And like I said, if it's been more than 3 episodes, that's when you need to think it's chronic suppurative lung disease. So it's starting to move into bronchiectasis territory or early stages of that, which is the thing we're worried about, which is why we want people to treat this aggressively. And then that's when you start referring. Irritative psychogenic cough is probably the hardest thing to deal with that we deal with. It's probably where you'd start referring them on. It's a diagnosis of exclusion. So once you go through everything else and find nothing else, that's when you're kind of stuck. They tend to be quite brassy or brash. By that, they're always honking. So it tends to be a honking cough. It usually isn't there at night, and it usually is not there with exercise, although that's not always true either. And usually it's more psychological type treatments. So there is a guy called Miles Weinberg who's got very good videos on how to deal with that, but it takes a lot of time. So even for me, in a busy clinic, I don't have time to do that. I refer them on to generally either physios or speech therapists. I'll touch on wheeze, but we'll talk a lot more about it at the second half. Wheeze makes paediatricians quite busy. So we think of wheeze as an evolving sort of definition, for me anyway, because I think we used to call them bronchiolitis and asthma, and now it's bronchiolitis, viral wheeze, asthma, which confuses everybody. And you'll find in the next few years that we're going to be moving back to asthma because no one really knows what the difference between asthma and viral wheeze is. So you'll see quite clearly here that it's just age related. Go back. In first couple of years of life, it's mostly bronchiolitis, right? And then as they get older, everyone gets called viral wheeze, and as they get older again, then you've got almost all of them asthma. It used to be all 100% asthma and none of that green before. You can actually, so that was for ED presentations. If you look at the same data, the emissions look exactly the same in terms of exponential decline. That's probably related to airway size that we were talking about. And then if you look at the viruses they all catch, generally in the first year, it's a lot of RSV, and thereafter, it's all the other. There's 3 species of rhinovirus. So if you ever get rhinovirus back, it's actually 1 of 3, and there's sort of 200 species. So most common is rhinovirus C, which actually only got discovered about 15 years ago when they started doing DNA sort of testing of viruses. And then the rest of them all are RVB. The B one's not very common. And then RVA is the one that you see more commonly in adults as you get a bit older. I'm going to keep it simple because you can argue about how you should differentiate between the two, and the truth is no one really knows. For me, I always ask about interval symptoms. So that's the key word, interval symptoms. And the interval symptoms are coughing at night, coughing with exercise generally. And if it's that, they've got symptoms outside of just having a virus. Again, if they've got back-to-back viruses, that can be very muddy as well. But in simplistic terms, if they have coughing with any of those things and you give them Ventolin and it's better, we start to think this is more sort of persistent asthma type picture rather than viral wheeze. And those ones tend to respond quite well to steroids. That's it. That's as simple as it gets. Not 100%, but that's the way I think about them. So if you go back to the child we're talking about, I would think that in terms of what do they have, it could be everything or nothing. So how do I deal with them? If it's not clear, I do a process of elimination. If they've been coughing for more than 4 weeks and it's more wet cough, try them on antibiotics. And you would say again, it's all about the language you use. You'd say, look, it's going to feel like experimenting, but it's not. It's sequential trial of treatment. So it'll be, I'm going to give you Augmentin, and I'm going to do this. You'll know in the next couple of weeks whether it's going to work or not. I'll bring you back in 2 weeks. If it doesn't work, then I'm going to consider another diagnosis. Then we might consider steroids for asthma. You have atopy, makes a higher likelihood that there might be asthma. We'll try that next. As long as they've got a clear plan of like, if the treatment works, then you have your diagnosis. And the only way we can work out the diagnosis is to treat, and then we work backwards from there. Most parents are quite happy with that. And then if nothing works, then I think then you're referring on. But I think our wait times now crept up at PCH to about 3 years. No one publishes that, but that's the reality. So I think we're trying to help you do as much as you can. And like I said, if it's PBB, you fix them, and it's the most satisfying thing. Okay, before I go on, does anyone have any questions? Is that clear to everyone? I'm not a heretic for talking about 6 weeks. Yes.
Can you tell me, do they grow out of the floppiness in the cartilage, the babies? Or are they left with a deformed, slit-like airway, as you described,
It's a good
acutely?
question. The more severe it is, I think they might not. And especially if they're moving all the time, you would think that they're more likely to keep as they get a bit older. So that kid with very severe might take longer to outgrow it, but they generally do. As the cartilage gets more rigid as they get a bit older, it tends to hold its structure. And when adults do bronchoscopies, they'll find rigid, round airway all the way down. So most of the kids we see won't be that bad. They'll be mild, so they mostly look normal, and then when they cough or they breathe, that's when it collapses. And it is immature cartilage. Sorry, she had a follow-on.
In former days when we were all younger, the sort of dogma was that if kids under 3 that wheezed had viruses, kids over 3 more likely to have asthma. Is that still true, or can that be consigned to history?
It's mostly true. Does that kind of make sense? Except the age groups keep changing in which people make. Because people keep telling me that you can't diagnose asthma under 4, and then sometimes 6. I think people just make stuff up, to be honest. But it's true. Like if you see that graph, that's why I showed you that exponential regression sort of graph. The more young you are, the more likely you are to outgrow it, right? So as you get up in the age groups, the more likelihood you have asthma because you're keeping it. That's all that exponential plot shows you, is that kids outgrow it. That's the truth of it, and it's an exponential regression with age. So by the time they get to 6, if you're still wheezing, you probably have asthma. So how many of those kids that are 1 they probably are asthma amongst that, but not all of them are. So that's the trickiness. So I wouldn't make it age threshold. Yeah.
Sorry, with the PBB, giving antibiotics for like Augmentin for 4 to 6 weeks in general practice, probably I would be a bit hesitant to do for that long without would you suggest doing a swab before we start the antibiotics, or how would you go about doing that?
I think the problem with that age group, most of these kids are going to be very young. They're not going to be able to give you a sputum sample. And a cough swab or swab at the back of the throat won't be representative of what's down in their lungs. You have a very clear clinical phenotype of wet cough. You give the antibiotics and it goes away. That's your like litmus test if you don't need investigations. The story will be very clear. You give them antibiotics, bring them back in a couple of weeks. For us, we don't have the luxury of doing that, so we have to bring them back 3 months later, but they're better after that. So we probably prescribe longer courses than you would on the grounds of, I'm not going to see them for 3 months, so I'm going to give you a massive course of antibiotics because I want to make sure it goes away.
Sure.
Does that make sense? That's
Yeah.
kind of...
No, thank you.
So in regards to PBB, when we have patients that I've treated with 2 weeks of antibiotics and they've resolved, but then maybe a week later they would develop another fever and runny nose again, and they start having that chesty cough again. Do we reset it for another 4 weeks for the chesty cough?
Yeah, that's a hard one. It depends on how sick that kid's been before, how worried that parent is. It's very individualised to the parent and their level of worry as well. But I try to convince parents to wait a couple of weeks, that usual viral course. So if it gets dry by the end, maybe they're fixed now. But if you see them again close to that 3-week, 4-week mark and they're still very wet, doesn't look like it's going anywhere, and you know what they've been like before, you would give them the course of antibiotics then. The next course you might not need to be 6 weeks. It might only need to be a couple of weeks. So you've caught it earlier. And I'd emphasise that as well. So I know you guys are probably quite busy as well. So fitting them in even at the 2-week mark might be quite difficult. Any more questions?
Just in relation, 2 questions. One, in the role of probiotics in children after prolonged courses of antibiotics, and also the role of allergies in children over 5, like desensitising for airborne allergies using something like oral air.
Actually see where that question came from. Scanning the room, but there's a lot of faces. You able to raise your hand so I can see where? Oh yeah, okay. Good question. Probiotics. I have a skeptical view about probiotics. There's good evidence that gut microbiome does contribute to asthma and things like that, but how much intervention for that actually helps is unclear. So it's going to be a complicated answer. On probiotics alone, what you can buy over the counter is sometimes not that good. So I usually just say, look, eat yogurt, have a healthy diet. Probably a better way to go and probably far cheaper. I think there's a bit of snake oil sort of sales going on with the probiotic industry. Some preparations are better than others. But when you look at the bacteria they're culturing, you'd probably just be better off taking yogurt or Yakult or something like that. That's my 2 cents on it. There'll be definitely people that would disagree with me about it, but that's my 2 cents. Families better off saving their money. In terms of allergies, yes, if it's sort of creeping into asthma and it creates more, like all of these things overlap. Like asthma is 1 in 10 kids. So you can have asthma, you can have malacia, you can have PBB at some stage because the inflammation is there. They all overlap, and then the asthmatics get more viruses than anybody else. So I see a common mix where I think it's all those things, because they're all common for what I see. So keep that in mind as well. It's not an Occam's razor type scenario where you go, it's definitely one thing.
My question was about what your non-penicillin alternative for augmentin duofort would be for kids that you need to treat
We
PBB.
like prescribing azithromycin, but we accept that that's in short supply at the moment. The next go-to would probably be cotrimoxazole for us, which comes in liquid as well as tablets. So that tends to work as well. What we're targeting is with the broader spectrum antibiotics, non-typal or Haemophilus, that tends to be resistant to plain penicillin, but quite sensitive to augmentin and some of the other broader spectrums. Yes.
Dr. Stephen, you mentioned to consider CSLD in cases of refractory, cases, antibiotic refractory cases. I was just curious to ask, what is the current gold standard to diagnose CSLD? Is it imaging or is it tissue diagnosis?
I think we will investigate it with everything. And I feel for you it would be clinical diagnosis. So if they just can't come off antibiotics, is basically the patients that you will see. And they're the ones we want to see. And generally, if you give us this story of, I have given 12 courses of antibiotics, they've run antibiotics almost continuously now for 3 to 6 months. We try to see them quite quick because we think there's probably something else going on. But we're trying to tease those out from the PBBs that are actually very easy to sort out. And then the rest of them, then they become a bit of a nightmare as to what's going on. You're trying to organise lots and lots of investigations to exclude severe things like cystic fibrosis. And that it kind of runs into that territory. No, it's not, because when you do the imaging, it'll be non-specific as well. If you've caught them late, they'll have bronchiectasis, but we don't want that. We want to catch them early so they don't then run into bronchiectasis. Some of the CSLDs will probably get better with age as well, but we usually start throwing the book at them if they can't come off antibiotics. Okay. How much I have to rush? Okay. 25 minutes. All right. 25 minutes to run through everything asthma. Okay. Asthma in WA. So about if you look at the numbers from all the age groups, it's very clear asthma is, for you, you'll see a lot of it in kids, less so probably in adults, or they're probably well controlled once they're a bit older from a getting very sick point of view. Keep in mind, like I showed you, this is a small pointy, and actually the wheezes that are not clear asthma at the very early, they triple to 5-10 times the number of whatever asthma is in kids. So for you, you would see a lot of this, I would have thought, in your GP practices. We see a lot of it in ED, which comes down to, we can go into why would you choose preventers and things, but if it's clear to you they're asthmatic, the main thing is convincing the family to use preventers properly is actually quite difficult. So the language that you choose is quite important to try to explain why they need it and why doing it sporadically once every second day or once a week doesn't work. This is how I explain it to patients. Your airways going into your lungs is like an upside down tree. You know, I was talking about tree analogies. So if you don't have a picture, this is the visual I'd use. You've got a tree trunk, which is your trachea or your windpipe, that branches into two sides and then branches into successively smaller branches till it reaches the end, which is the leaves, which is your alveoli, which exchange your gas, your CO2 and your oxygen, which makes you breathe. That's the whole mechanism of your airways going into your lungs. Now, when you think about trees and a tree gets sick, you'll notice that not all the branches are affected equally all the time. You'll get a couple of dead branches. You'll get some that look a bit sick and some that are very green. Asthma is the same. Doesn't always affect. I can show you lots of fancy studies, but you should know that as well just from listening to patients' chests. If you listen to an asthmatic's chest, you'll listen to the right side up the top. Sounds pretty clear. Listen to the left side all round, sounds pretty silent, and then you listen to the right base and it might be wheezy. That tells you straight away that not all the airways are equally affected. Everyone happy with that? If that's what you actually experience? What does that tell you? It tells you that not all the airways are equally blocked, because the whistling and wheezing you hear is from blockage of the airways. You hear nothing if they're completely blocked or critically blocked. So it looks like this. If you've got plumbing problem, you have one main airway, lots of smaller branches, and if they're all individually blocked to a various extent, this is what it looks like. Now, this is a problem when you are using in-house steroids, because if you've got one airway that's open, one's very closed and blocked, where do you think all your medicine goes? This is a daunting, this is like mind revelation when you talk to a patient's family like this. It all goes in there. None of it goes in there. And you want a lot of it to go in there, but it's going to take some time for that to open up. And then it's a Drano problem, right? You're throwing your steroid, and I say this way, is Drano. It's going to slowly chip away and open that up, but it's going to take some time. And if you stop, the gunk is going to come back. So it's a maintenance. Once you're on maintenance, then you can sort of drop the dose back and keep everything open. That's your best case scenario. That kind of makes sense. It also explains why you need protocol in ED, because if your airways are critically closed, the only way to get that open is oral steroids. And the only way that you're getting Ventolin in is if you give maximal amount of Ventolin in a short burst. And if you stretch them too quick, they end up back here again with bronchospasm. So you don't stretch them too quick either in ED. That's often mind-blowing for ED people as well. It's like, this is the physiology that you're dealing with. That's how I think about asthma. It's not everyone thinks about asthma that way. Which inhalers do you prescribe? I find that previously to becoming a respiratory person, it used to just be orange puffer, purple puffer. Is that everyone else's practice today? Yeah. But then you send them out to a respiratory clinician and they use all of these. And you're like, why are they doing that? It's crazy. Why not just stick to the simple stuff that works? Let me give you some reasons. Is everyone aware of preventers of greenhouse gas? So your canister of Ventolin or Symbicort, that canister is worth 25 to 35 kilos of CO2. 35 35 kilos CO2 is Perth to Bunbury trip, which I did on Thursday to do a clean. It's quite a lot of greenhouse gas. It represents about MDIs alone, so the meter dose inhalers, they represent 2 to 3% of the total NHS output. You know, hospitals and the health sector is a major greenhouse gas producer. You imagine just your inhalers represent 2 to 3% of all the greenhouse gas output. It's enormous. So we really should be thinking about trying to move, to dry powder inhalers if you can. The caveat being that dry powder inhalers, you can only prescribe to kids over 8. And even then in the 8 to 12-year-olds is always a bit skeptical about how well they're going to use it. So in the little ones, they don't have a choice, but in the older ones, I think it's a conversation worth having, or if you're starting someone for the first time that's a bit older, thinking about dry powder inhalers. The preparations for them are often more convenient as well. How effective do devices deliver? This is the other thing that I educate parents around, which hopefully will be helpful for you as well. If you use your MDI without a spacer, the amount that gets into your lungs, if you are really good, is about 5%. In a kid that can't coordinate their breath with the spray, it's probably about 2-3%. Some will go in, but you definitely don't want the preventers to be given this way. If you use a spacer, it's about 50%. It's a massive difference if you just change them across to using their spacer. I often quiz the families, 0 to 100, how much of that do you think gets into your lungs if you don't use a spacer? They always say 50%. I don't know why. And then when I tell them it's less than 5%, they're usually quite shocked. Often leads to behaviour change. Nebulizers don't deliver that well either. Most of it goes into the air, but you're giving it continuously in a higher dose, so it's less of an issue. Oh yeah, and the dry powder inhalers, the discus devices are horrible. I think it's slightly better they've redesigned them, but the really old ones, 15%, pretty bad. Turbihalers are about 50% as well. They're the clicky devices screw at the bottom. You start to realise that there's all these devices and the education becomes quite hard. There's all these preparations. So I think use your asthma educators out there, and they're in respiratory care WA. It used to be asthma WA. It takes a lot of time if you do it yourself. Trust me on that. Things that people need to be aware of as well. Why I don't like Seretide. If you look at the half-life of salmeterol, this might not be entirely true, but this is sort of like plasma half-life. But I think it probably reflects on a range that you'll see within the airways as well. 5.5 hours. If you think about half-lives, generally 2 half-lives and most of the medication's not working anymore. So you don't even get to 2 half-lives when you're giving BD dosing of Seretide. And so if you have a patient that's on Seretide and they report early morning symptoms and late evening symptoms, and we see quite a lot of them, it's because of that. Stop working. And if you change them to Symbicort, which has a much higher half-life, it usually gets rid of that problem. On PBS, it's also a bit cheaper on Symbicort, but you need in the under 12s, you need a respiratory or a paediatrician to sign off on it. So I think we have a community service in order to try to facilitate some of these conversions if you need it. And we're trying to find ways of doing that and doing that a little bit better all the time. I hope everyone's aware that there's once-a-day preparations that the adults and over 12s can be on, Brio. So that's just long-acting fluticasone and Vilanterol, which is a 24-hour LABA preparation. Most patients, especially the 12-year-olds, love this. They can't speak higher of only having to do it once a day when they're quite busy. And the ICS-only version of that's only if they don't need the LABA. Hopefully that's not news for people, but I find these particularly useful for kids, particularly the teenagers. How much time? Okay, try to spend 5 minutes on this. What do you do with the less than 4 wheezes? Basically, come last year, they're basically saying it's all the research shows that trying to distinguish between viral wheezes and asthmatics when you're looking at them at a younger age, nothing's really predictive. You know, if you take a clinical history, it's not that helpful. So now we're back to trying to relabel all the viral wheezers as asthmatic again, and then trial a treatment with inhaled corticosteroids being what people are starting to advocate for. And that is, oh, hang on, sorry. Yeah, so I won't dwell too much on that for time. So treatment options for the 0 to 4 year age group. There's been lots of studies. The problem with all of these studies is some of them are quite small, and some of them you're not sure if they're just picking out wheezers versus asthmatics, because like I said, like there's nothing in terms of markers that will tell you other than looking at them at an older age group and looking back, which no study is designed to do that. So take all the evidence with a pinch of salt. If you only use Ventolin with these, a lot of them will get quite a lot of oral steroids. If you have 4 to 5 courses of oral steroids in a year, you triple your fracture risk on studies for that year. So probably not the greatest way to go. If you give daily low dose inhaled corticosteroids for the viral wheezers, it doesn't work as large. It will work for some, but not all, and maybe those ones are the asthmatics. And if you look at the meta-analysis for it, which starts to get a bit confusing, because if you look at the preschool asthmas, which is this, in terms of exacerbations, you can see there's a good treatment effect if you put them on inhaled steroids when they're this like group of wheezers and asthmas. It does work. So clearly there is some evidence. But if you pick them out as viral wheezers, this is with intermittent steroids with very small numbers, like 23 in each branch. You get this sort of treatment effect. So you'd think that sometimes putting on regular steroids should work, but we'll come back to that at the end. Daily Montelukast does work as well in some of the studies. So this is the survival plot of hospital admissions. This is Montelukast, clearly better than placebo. Intermittent Montelukast doesn't stop hospitalizations, but does reduce symptoms. And then taking low dose inhaled corticosteroids at the first sign of symptoms. Some people do this. If you give the doses that most people give at 50 micrograms or 100 micrograms twice a day, it doesn't work on the biggest studies. But if you give 750 micrograms, 15 puffs twice a day, it does work. Is anyone going to do that? You haven't hard enough time trying to convince families to take the steroids, let alone give 15 puffs. Or even if you convert them to the 250, you get a bit worried if they didn't stop and went to see someone else in the interim, kept doing that. So on the RCH latest guidelines, which we use in ED now, they advocate for basically if they're very mild, give them nothing because they're not going to get oral steroids. If they're a bit more less mild, give them Flixitide. I have problems with this as well, because what if they only get one exacerbation per year, but then they always go to hospital? Are you going to start them on Flixitide? Are the family going to give them that for the entirety of the year? You think yes? I would say if you follow those families up, unless they are very worried, most of them don't give it regularly because they're like, why am I giving my child this when they're not sick? Yeah, that is one strategy. But I've already shown you the evidence that it doesn't work that well. So I'm hard convinced to say, look, if it's more viral wheeze, is it going to work that well? I'm not sure. We have lots of them that we give like everything to, and they still keep coming back to hospital. So I think it's not that clear cut. And you're trying to reduce steroids if possible, so you're giving them it for the entirety of winter for maybe one exacerbation, which also becomes quite a hard thing to sell to a lot of families. So you were talking about winter, like we were talking about. Winter's probably a better strategy for these. But some of them will get it in the spring months and autumn. So you're then running autumn, winter, spring, which is like 9 months of the year. So it's not that clear cut. Once if you start fluticasone and they still aren't over hospital for 3 days, you're going to make them stronger. It's like one admission. Yes. Yeah, it can. Yeah, so I'll tell you exactly what I tell them. It typically will cause behaviour disturbance in almost everyone within the first couple of days that you start it, generally within the first couple of weeks. If you are good on it in the first couple of weeks, you don't have to worry about any more behaviour disturbances and sleep issues and mood problems. don't creep up on you later down the track. So as long as when you're initiating it, you're mindful that if your child's not right, stop straight away and it will go away just as quickly as it starts. It's less of a risk if you know that. It's more of a risk if you don't tell patients about that. So you just say, look, we're aware that this is a thing that people experience. If you get these things, stop it straight away, and you'll notice it almost immediately after you start the medication. Does that make sense? That's what I tell all the patients when I start it. It's a very good question. I thought I had a slide on it, but clearly I've taken it out. So the GINA guidelines actually have, based on 2 studies, RCTs. Whenever you take SABA, take low-dose ICS, almost like a smart therapy for little ones. But this isn't the problem group. 6 to 11 is not the problem group. The less than 6s are the problem group for viral wheeze. So my thoughts would be, I do that. I do that plan in the less than 6s because I can't justify high dose in corticosteroids, and I'd rather them titrate the dose up. So I think some of you that have seen patients that have sent to me will get patients with this plan coming back. And I actually send them with a printed copy of this. I give them, every time they use salbutamol and it works, I get them to chase it with 2 puffs of Flixitide. They use salbutamol again in a couple of hours. So it's loading up early, much in the same as smart therapy plans. I think going forward, this probably needs to be studied because I think it's the most sensible approach and avoids oral steroids. So this is what I would do. There is no evidence to drive this in the less than 6 age group. Just keep that in mind. But it seems to make the most common sense thing to do. Just quickly on the respiratory care WA. So this used to be Asthma WA. We run community service for quicker entry and faster seeing them with more comprehensive assessments. We do lung function in those above 4. It's free bulk build. We are in Joondalup. Just did one in Bunbury. We're in Coburn as well as in West Perth, the main office. We do 3 sorts of lung function tests. We do FeNO, which measures allergy inflammation, which 4-year-olds can surprisingly do quite well. Spirometry doesn't tend to be a successful test until they're over 6. And the main one that we use in kids and we lean a lot on is this thing called FOV, which uses sound waves to measure resistance and stiffness in the airways. And then you can give Ventolin and see if there's a big effect. So just to show you what that looks like, if you could play that video, I think we've got time. Sorry. Sorry, this is their promo video for one of the things, but it gives you an idea of what the machine looks like and how easy it is. This is what the machine, it looks like a glorified space heater, but only costs $20,000 or more now with inflation.
Take this and put it on your nose.
But send sound waves down so it wobbles, so you have to hold your cheeks. That's what she's going to do. We're usually a bit gentler than that. And it wobbles. Sends sound waves down, uses sound waves and complicated physics, which my brain's too small to understand to measure all of the airway properties. There's some hole. And that's done. That's what easy, right? We can do that in 4-year-olds. Sometimes a really good 3-year-old. But it means that you get a lung function result. And it looks like this. So the resistance spits out. Generally, the lower the frequency, the greater the penetration to the peripheral airways. So we look at 5 to 7 hertz as being representative of your small airways, which are most affected in asthma. So it gives you an upper limit of normal because you've got studies that give you a range of normal now. And then basically you give Ventolin, you can see the resistance drop. Anything more than 40%, I think now it's sort of creeping down into the negative 30% mark is a significant change. And then the reactance, which is wobbliness. If the airways are stiff, reactance is low. That's the best way of thinking about it. You can see it change. You'll never have to read this report. You'll get something from me saying it's good tests or it's normal or it's not normal, it's basically. But it's useful for me because I see them in clinic and go, well, you have more viral wheeze pattern, but you are clearly sitting here at baseline in this office not exercising and you're not right, you're asthmatic. So for me, it's very clarifying, so it's useful to do. And this same kid, this is their spirometry, and they couldn't do spirometry very well. So the spirometry was useless and the fault was diagnostic. That's why we do it. Any questions? Yes.
Just a quick question, sorry. Am I right in thinking the oral steroids are still reserved for the sort of moderate severe asthma that tends to present to hospital, not sort of more
If you're
GP
worried,
land?
give them the oral steroids. You just have to keep in mind the side effect profile of them, the restriction of growth, and then you've got, there's growing evidence that there's cumulative effect as well of osteoporosis risk over time if you're giving multiple successive courses of steroids year in, year out. And we do end up with a whole bunch of people in the older age group that the respiratory adult doctors have to deal with that would be effectively respiratory cripples with bone diseases because of the quantity of oral steroids they've had through their lifetime. But if you have to give it, you have to give it, right? But the ideal would be getting them on the right preventer so that you're getting inhaled steroids at the right dose to where it's needed. That takes some titrating sometimes.
Where does cow milk allergy fit into wheezing for a little baby? And do they grow out of it, or do you replace them with goat's milk? What's the current story?
I think in terms of most milk protein allergies aren't associated with wheeze, but it's possible that allergies can drive other things. But I think they tend to outgrow most milk protein allergies. So for a period of time, if you substitute them on, I think the one that we normally use is do GMPs, but it's the rice-based formula tends to be the easiest one to go to, but it's the hardest one to find in chemists because it's popular in China and gets shipped off to there. Someone will remember what it is. I used to have it rattled in the top of my head. If someone wants to shout out which one that is, so for a period of time you might put them on something like that for a bit if you're worried. Can't hurt. It'll come to me as soon as I get off the stage. There is an overlap with goat's milk and cow's milk allergies, the thing that I'd be worried about. Sometimes it doesn't work.
For those kids who needed the Montelukast, because it's like step 4, why do you still keep them on the fluticasone?
Oh, I think it's the add-on. You could start with Montelukast. I think the RCH guidelines are very prescriptive. Don't leave a lot of room for the confusingness of the evidence. I showed you, right? You could pretty much do everything in viral wheeze and you wouldn't be absolutely wrong. There'll be a study that backs you. If you look at the studies, they're confusing as hell because you're not sure of the patient selection. They're small groups. There's often big conclusions drawn around imperfect studies. So I think you could, Montelukast is brilliant for some patients. Like you get super responders that fixes everything. When you have a patient that responds to Montelukast, you will be their best friend. They'll come back to you and they'll say, "You fixed him, doctor. No one's been able to do this." And they'll send you a present every year. That's how joyful they are about it. When it works well, it works really, really well. When it doesn't work, it's useless sometimes. And there's a big mix of patients in terms of their responsiveness. So I do start them on Montelukast first sometimes because some kids just don't like taking preventers inhaled. And Montelukast is really pragmatic. Comes in a chewable tablet. Tastes really nice for most kids. It's the easiest one to take and they'll take it no problems. We get reports of little ones stealing it out of their mum's handbag because they think of it as lollies. That's how easy it is to take. So when it does work well, but you have to temper that with the neuropsych side effect profile. Like you have to make sure you tell them you will either get in 1 in 6 kids, you'll get behavior, mood, or sleep disturbance. If that happens, it'll happen quickly. If you stop it, it goes away. If you're not sure if they had a bad week, you'll do it again in another week and it'll be exactly the same thing again if it's the medication. Another one at the back. There's a lot of misinformation in this space. So if I'm confused, you should be doubly confused.
Yeah, I just want to clarify one thing. You said about asthma has to be treated quite regularly, right? I just want to clarify one thing about that virus wheeze, that less than 6. You just give the acute treatment with the steroid, and then we stop. That's only for virus wheeze. Am I correct? If you diagnose with asthma, is that still possible?
If it's true asthma, the pathology of true asthma is you've always got baseline airway inflammation.
Yep.
So in the viral wheezes, you presume they don't have baseline airway inflammation. They only get inflamed airways when the virus hits them. Does that make sense? And you're trying to temper how severe inflammation gets without using oral steroids, ideally.
Yeah, of course. Yeah, I just asked this question because I got a lot of parents coming in. They told me that the doctors or even a specialist asked them to do it for their asthma. Just use it when you need it for steroid buffer.
But everyone prescribes that sort of 2 puffs of Flixitide twice a day just as soon as you get unwell. It works for the odd kid, but for the majority, it doesn't work that well.
Yeah.
I feel that they will go back to you and say, it doesn't work that well, doctor. Like, I'm just trying to give different options that might actually work. So I think keep that in mind. But I'm the only one that does that. So my colleagues won't do that as well because there's no evidence to drive it just yet. But I think it does work in the over sixes. So by extension, you'd think it should work in the under sixes as well. Just no one's been game enough because of the complexity of studying that age group to do it just yet. It's confusing. Over sixes, you can tell the viral wheezes. Under sixes, they're all this sort of mixed bag.
I've got a 6-year-old who's across 2 clinics at PCH, gastro and respiratory, with confirmed asthma on Montelukast. He's still soiling himself when he's too busy to bother going to the toilet. I'm wondering if that's the Montelukast.
Hard to know. It's not a common Montelukast side effect. I would say in that age group, it's quite common that they get busy and then they hold on for too long. So it's hard to know whether that's just him playing too much and then soiling him. When you say soiling, I assume it's urinary incontinence. Very cool. So I'd be more worried about him being chronically constipated or something else going on. Yeah, they're tricky, those patients. I think they're really difficult to sort. I think they often need time toiling. Even that doesn't work that well sometimes in regular laxatives. The gastros will sort those in the end but sometimes they do everything and it's still really difficult to get on top. I've had a couple of patients like that where it's really difficult to deal with. No, it's probably not the Montelukast. But if you're not sure the Montelukast is working that well, you can always stop it and see. I try not to do that in winter, though.
All right. Thank you so much. That was a really fantastic presentation. Thank you. Just a little something to say thank you for today. Thank you.
Thank you very much.